Welcome to Study Session 4, Nasogastric Tube, NGT, and Jejunostomy Feeding. Introduction. A nasogastric tube is a narrow-bore tube passed into the stomach via the nose. It is used for short or medium-term nutritional support and also for aspiration of stomach contents, e.g., for the compression of intestinal obstruction. A wide-bore tube is used if drainage is needed. Otherwise, a finer bore tube is used. Fine-bore feeding tubes cause less discomfort and less risk of rhinitis, pharyngitis, or esophageal erosion. In this study session, you will be learning about nasogastric tube, the purpose of insertion, requirements before insertion, actions involving insertion and removal. You will also learn about gastrostomy feeding administration. Purpose of insertion of the NGT. NGT is a plastic or rubber bore tube with holes near the tip of various sizes, diameter measured, inserted into the stomach for the following purposes in client's care. 1. To administer feeds to clients who are unable to ingest food. 2. To administer medication. 3. To decompress the stomach of fluids or gases. 4. To prevent nausea, vomiting, gastric distension following surgery or traumatic event by decompressing the stomach. For diagnostic studies needed to remove the stomach contents for examination and analysis. 6. To lavage or irrigate the stomach in cases of poisoning or medication overdose. Requirements needed for the insertion of the NGT. Examples of NG tubes are Levin's tube, Ryle's tube, and Salem-Sum tube. Observe client's alertness and awareness of the surrounding and ability to communicate with the nurse. Identifies client's ability to understand and cooperate. Determine the purpose of the intubation. Rationale. Indicates the type of equipment to be used. Determine the client's ability to breathe through his or her nostrils. Instructs clients to blow his nose. Close one nostril with the finger. Tell the client to exhale. Repeat with the other nostril and compare the force of exhalations. Review client's health history for nasal trauma, bleeding or nasal surgery. Rationale. Suggests closed nostril. A deviated septum may permit easy passage of air but be painful for the client when tube is passed. Ask the client to open his mouth and stick out the tongue. Tap the soft palate at the back of the tongue blade and see if the gag reflex is present. Rationale. Alert the nurse to possible blocks from scar tissue or to friable nasal tissue. Indicates the client is able to assist with the passage of the tube by swallowing liquid. The gag reflex protects one from aspirating liquid as it is being swallowed. The nursing diagnosis and related factors. Altered nutrition, less than body requirement. Evidence of insufficient intake of nutrients to meet metabolic needs. Requirements. Items. Topical anesthetic agent. Rationale. Provides topical anesthesia. Glass of water and straw. Assists the client to swallow the tube. Towel. Protects the clothing and linings. Clamp. Closes tube after insertion if necessary. 20 ml syringe. Withdraws stomach content to check accurate positioning. Clean gloves. Protect the nurse's hand from contamination. Scissor. To cut tape in appropriate size and shape. Actions and rationales involved in the insertion of a NGT. Preparation. Before starting a tube feeding. 1. Introduce self and verify the client's identify. Explain to the client what the procedure is about and why it is necessary and how he and she can cooperate. Rationale. This facilitates the client understanding and tolerance of the procedure, as the passage of a NGT is unpleasant due to gag reflex, is activated during insertion. 2. Establish a method for the client to indicate distress and a desire to pause the insertion, such as raising a finger or hand to alert the nurse. Assist the client to high Fowler's position if not contraindicated, and support the head on a pillow. Also place a towel or disposable pad around the client's chest and have an emesis basin and tissues handy. Rationale: upright position facilitates easy swallowing and prevents aspiration if client should vomit. Passage of tube may stimulate gagging and tearing of eyes. Action 1. Perform hand hygiene. Hand washing deters the spread of microorganisms. 2. Provide privacy for client. 3. Prepare the tube by straightening it out to facilitate easy insertion. 4. Determine the length of the tube to be inserted by placing the tip of the NGT at client's nostril, extending it to the tip of earlobe and then to the tip of xiphoid process. Mark the tube with a piece of tape if the tube does not have marking. This measurement approximates the distance and length from the nurse to the stomach and ensures that the tube will be long enough to reach the client's stomach. 5. Put on gloves. 6. Lubricate the first 10 to 20 cm, 4 to 8 inches of the tube with a water-soluble lubricant. Rationale: lubrication reduces friction and facilitates passage of the tube into the stomach. Water-soluble lubricant will cause respiratory complications if tube enters the lung. 7. Ask the client to lift his head and insert the tube into the nostril while directing the tube downward and backward, following the natural curve. The client may gag when the tube reaches the pharynx. Rationale: hyperextension of the neck reduces the curvature of the nasopharyngeal junction, also following the normal contour of nasal passage, while inserting the tube reduces irritation and the likelihood of mucosal injury. The gag reflex is readily stimulated by the tube. 8. Instruct the client to keep head in upright or normal eating position. Encourage him or her to swallow even if no fluids are permitted. Advance the tube in a downward and backward direction when the client swallows. Stop when the client breathes. Provide tissues for tearing or watering of eyes. If gagging and coughing persist, check placement of tube with a tongue blade and flashlight. Keep advancing the tube until the tape marking is reached. Do not use force. Rotate the tube if it meets resistance. Rationale: bringing the head forward helps close the trachea and open the esophagus. Swallowing helps advance the tube, causes the epiglottis to cover the opening of the trachea, and helps to eliminate gagging and coughing. Tears are a natural response as the tube passes into the nasopharynx. Excessive coughing and gagging may occur if the tube has curled in the back of throat. Forcing the tube may injure mucous membrane. 9. Discontinue the procedure and remove the tube if there are signs of distress such as gasping, coughing, cyanosis, and the inability to speak or hum. Rationale: the tube is not in the esophagus if the client shows signs of distress and is unable to speak or hum. 10. Determine that the tube is in the client's stomach. These methods are appropriate for large bore tubes, but may be ineffective to check placement of small bore pliable tubes. Attach the syringe to the end of the tube and aspirate 10 to 20 mm of stomach content. Rationale: tube is in the stomach if its contents can be aspirated. Measure the pH of aspirated fluid. Rationale: the pH of gastric content is acidic 1 to 5 compared with an average pH of 6 to 0 or greater for respiratory fluid or intestinal tract content. Because pH of intestinal fluid also is slightly basic, this method will not effectively differentiate between intestinal fluid and pleural fluid. Place 10 to 20 ml of air in syringe and inject air into the tube. Simultaneously, auscultate over the epigastric area with a stethoscope. Rationale: a whooshing sound can be heard when the air enters the stomach through the tube. Place the end of the tube in a kidney dish with water. Rationale: bubbles are seen if tube is in the lungs. 12. Attach tube to suction and drainage bag or cork the end of the tube. Rationale: suction provides for the compression of stomach and drainage of gastric contents. Closure of the tube at the end prevents the entrance of air if the tube is meant for feeding. 13. Secure tube to the client's gown by using a rubber band or tape and a safety pin. This prevents tension and tugging on the tube. Wash hands. Remove all equipment and make clients comfortable. Then carry out the following: observation, teaching, documentation of the procedure. Removing a nasogastric tube assessment. Assess for the presence of bowel sound. Assess for the absence of nausea or vomiting when tube is clamped. Requirements: disposable pad or towel, tissues, clean gloves, 50 ml syringe, plastic bag or destructor bowl. Client's preparation and instruction on specific details such as neck positioning and swallowing of the tube when in the throat. Rather, etching may enhance client's cooperation and an easy insertion. The length of the tube before insertion must be measured and marked from tip of nose rails to the tip of the earlobe and then to the tip of the xiphoid process. After insertion, the placement of the tube in the stomach must be ascertained. Implementation. Preparation. Confirm the physician order to discontinue or remove the NGT. Introduce self and verify the client's identity. Explain to the client what the procedure is about and why it is necessary, and he and she can cooperate. Rationale. This facilitates the client's understanding and tolerance of the procedure. Assist the client to a sitting position if not contraindicated. Place the disposable pad or towel across the client's chest to collect any spillage of secretions from the tube. Provide tissues to the client to wipe the nose and mouth after tube removal. Action. Perform hand hygiene. Hand washing deters the spread of microorganisms. Provide privacy for the client. Detach the tube. Disconnect the nasogastric tube from the suction apparatus, if present. Unpin the tube from the client's gown. Remove the adhesive tape securing the tube to the nose. Remove the nasogastric tube. Put on clean gloves. Instill 50 ml of air into the tube. This clears the tube of any content such as feeding or gastric drainage. Ask the client to take a deep breath and hold it. This closes the glottis, thereby preventing accidental aspiration of any gastric content. Pinch the tube with a gloved hand. Rationale: pinching the tube prevents any content inside the tube from draining into the client's throat. Smoothly withdraw the tube. Place the tube in the plastic bag and destructor bowl. Rationale: placing the tube immediately in the bag or destructor bowl prevents the transfer of microorganisms from tube to other articles or people. Observe the intactness of the tube to identify if any part of the tube is broken. Ensure client's comfort. Provide mouth care if desired. Assist the client as required to blow the nose. Excessive secretions may have accumulated in the nasal passage. 6. Dispose the equipment properly to prevent transmission of microorganisms. 7. Document the procedure, the amount and appearance of any drainage if connected to suction, and other necessary assessment findings on the client. Evaluation: carry out a follow-up examination to evaluate the presence of bowel sound, absence of nausea or vomiting, intactness of the tissues of the nares. Relate the findings to previous assessment data, if available. Report significant deviations from normal to the physician. Administering is nasogastric tube feeding. It is an enteral method of feeding carried out to ensure adequate nutrition through a NGT inserted from one of the nostrils into the alimentary tract. It is important to note that NGT feeding is carried out in clients who have adequate gastric emptying and require short-term feedings. Assessment: for any clinical signs of malnutrition or dehydration, for allergies to any food in the feeding, for presence of bowel sounds, for any problem that suggests lack of tolerance of previous feeding, e.g., delayed gastric emptying, abdominal distension, diarrhea, cramping or constipation. Requirement or equipment: correct type and amount of feeding solution, feeding barrel, 50 ml syringe, measuring container from which to pour the feeding, water in a cup at room temperature, kidney dish, clean gloves, 20 ml syringe, pH test strip or meter. Implementation: preparation: before starting a tube feeding, identify the client and check the client's treatment sheet for any prescribed order regarding NGT feeding. Determine the type, amount, and frequency of feeding. Assist the client to a fowler's position, at least 30 degrees elevation, in bed or a sitting position in a chair, the normal position for eating. If a sitting position is contraindicated, a slightly elevated right side lying position is acceptable. Rationale: these positions enhance the gravitational flow of the solution and prevent aspiration of fluid into the lungs. Action: 1. Introduce self and explain to the client the procedure, its importance, and how he or she can cooperate. Inform the client that the feeding should not cause any discomfort, but may cause a feeling of fullness. Perform hand hygiene and put on a clean glove. Provide privacy for this procedure if the client desires it. Tube feedings are embarrassing to some people. Assess tube placement. Dip the end of the NGT in a kidney dish with water for air bubbles. Air bubbles are seen if tube is in the lungs. Or check the pH by attaching a syringe to the open end of the tube and aspirate. Allow 1 hour to elapse before testing the pH if the client has received a medication. 5. Assess residual feeding content. If the tube is placed in the stomach, aspirate all contents and measure the amount before administering the feeding. Rationale: this is done to evaluate absorption of the last feeding, that is, whether undigested formula from a previous feeding remains if the tube is in the small intestine residual content cannot be aspirated. If 100 ml or more than half of the last feeding is withdrawn, check with the nurse in charge or refer to agency policy before proceeding. The precise amount is usually determined by the physician order or by the agency policy. Rationale: at some agencies, a feeding is delayed when the specified amount or more of formula remains in the stomach, or reinstill the gastric content into the stomach if this allowed by the hospital policy or the prescribed order. Rationale: removal of the content could disturb the client's electrolyte balance. If the client is on a continuous feeding, check the gastric residual every 6 hours or according to the hospital policy. 6. Administer the feeding. Before administering feeding, check the expiration date of the feeding. Warm the feeding to room temperature. An excessively cold feeding may cause abdominal cramps. If syringe is used, remove the plunger from the syringe and connect the syringe or feeding barrel to a pinched or clamped nasogastric tube. Pinching or clamping the tube prevents excess air from entering the stomach and causing distension. Add the feeding to the syringe barrel. Permit the feeding to flow in slowly at the prescribed rate. Raise or lower the syringe to adjust the flow as needed. Pinch or clamp the tubing to stop the flow for a minute if the client experiences discomfort. Rationale: quickly administer feedings can cause flutters, cramps, and/or vomiting. 7. Add water before the feeding solution as drained from the neck of a syringe and from the tubing of an administration set. Rationale: adding water before the syringe or tubing is empty prevents the instillation of air into the stomach or intestine and thus prevents unnecessary distension. Clamp the feeding tube before all the water is completely instilled or drained. Clamping prevents leakage and air from entering the tube if done before all the water is instilled. Ensure client's comfort and safety. Secure the tubing to the client's gown. This minimizes pulling of the tubes, thus preventing discomfort and dislodgement. Ask the client to remain sitting upright in Fowler's position or in a slightly elevated right lateral position for at least 30 minutes. These positions facilitate digestion and movement of the feeding from the stomach along the alimentary tract and prevents the potential aspiration of the feeding into the lungs. 10. Dispose of equipment appropriately. If the equipment is to be reused, wash it thoroughly with soap and water so that it is ready for reuse. Change the equipment every 24 hours or according to hospital policy. 11. Document all relevant information. Document the feeding, including amount and kind of solution taken, duration of the feeding, and assessment of the client. Record the volume of the feeding and water administered on the client's intake and output record. 12. Monitor the client for possible problems. Carefully assess clients receiving tube feedings for problems. To prevent dehydration, give the client supplemental water in addition to the prescribed tube feeding as ordered. Evaluation. The evaluation should include urine analysis for glucose acetone. For an effective understanding of discussed procedure, the following points must be borne in mind. To enhance client cooperation, explain to the clients that NGT feeding does not cause any discomfort but may cause a feeling of fullness. For a safe administration of NGT feeding, the client must be accessed prior to the procedure for the tube placement, residual feeding content, and tolerance to previous feeds. During the NGT feeding, we must prevent the instillation of air so as not to cause GIT distension. Administering a gastrostomy or jejunostomy feeding. It is an enteral method of feeding that is carried out to ensure adequate nutrition through a gastrostomy or jejunostomy device. The assessment is similar to that of the nasogastric tube. Equipment: correct amount of feeding solution, graduated container and tubing with clamp to hold the feeding. Feeding barrel: 50 ml syringe. For a tube that remains in place, mild soap and water, clean gloves, petrolatum, zinc oxide ointment or other skin protectants. Pre-cut 4 inches by 4 inches gauze squares, uncut 4 inches by 4 inches gauze squares. For tube insertion, clean gloves, moisture-proof bag, water-soluble lubricant, feeding tube. Implementation and procedure. Preparation. Before starting a gastrostomy or jejunostomy feeding, identify the client and check the client's treatment sheet for any prescribed order regarding gastrostomy or jejunostomy feeding. Determine the type, amount, and frequency of feeding. Obtain any pertinent information about previous feeding, such as the position in which the client best tolerates the feeding. Action. Introduce self and explain to the client the procedure, why it is necessary and how the client can cooperate. Perform hand hygiene. Provide privacy for the client. Insert a feeding tube if one is not already in place. Put on clean gloves. Remove the dressing. Then discard the dressing and gloves in the moisture-proof bag or destructor bowl. Put on new clean gloves. Lubricate the end of the tube by dropping an adequate amount of water solute on the tip of the tube. Ensure that the lubricant container do not have any direct contact with the tube. This prevents the contamination of the tube. Insert the tube in the ostomy opening, 10 to 15 cm, 4 to 6 inches. Check the location of patency of a tube that is already in place. Determine the correct placement of the tube by aspirating secretions and checking the pH. Follow the hospital policy for amount of residual formula. This may include withholding the feeding, rechecking in 3 to 4 hours, or notifying the nurse in charge or the physician if a large residual remains. For continuous feedings, check the residual every 4 to 6 hours and hold feedings according to agency policy. Remove the syringe plunger. Pour 15 to 30 ml of water into the syringe. Remove the tube clamp and allow the water to flow into the tube. Rationale. This determines the patency of the tube. If water flows freely, the tube is patent. If the water does not flow freely, notify the nurse in charge or physician. Administer the feeding. Hold the feeding barrel or syringe 7 to 15 cm above the colostomy opening. Slowly pour the solution into the syringe and allow it to flow through the tube by gravity. Just before the formula has run through and the syringe is empty, add 30 ml of water. Water flushes the tube and preserves its potency. If the tube is to remain in place, hold it upright, remove the syringe, and then clamp or plug the tube to prevent leakage. If a catheter was inserted for the feeding, remove it. Ensure client's comfort and safety. After the feeding, ask the client to remain in the sitting position or a slightly elevated right lateral position for at least 30 minutes. This minimizes the risk of aspiration. Assess status of peristomal skin. Rationale. Gastric or jejunal drainage contains digestive enzymes that can irritate the skin. Document any redness or broken skin areas. Check orders about cleaning the peristomal skin. Apply a skin protectant and appropriate dressings. Generally, the peristomal skin is washed with mild soap and water at least once a day. The tube may be rotated between the thumb and forefinger to release any sticking and promote tract formation. Petrolatum, zinc oxide ointment, or other skin protectant may be applied around the stoma, and pre-cut 4 inches by 4 inches gauge squares may be placed around the tube. The pre-cut squares are then covered with regular 4 by 4 gauge squares, and the tube is coiled over them. Observe for common complications of enteral feedings: aspiration, hyperglycemia, abdominal distension, diarrhea, and facial impaction. Report findings to the nurse in charge or physician. Often, a change in formula or rate of administration can correct problems. When appropriate, teach the client to administer feedings and when to notify the healthcare provider concerning problems. Document all assessment findings and interventions. Evaluation. The evaluation should include peristomal skin condition, in addition to the evaluation step done in earlier stages. For an effective understanding of discussed procedure, the following points must be borne in mind. To facilitate easy insertion of the tube into the ostomy opening, the end of the gastrostomy or jejunostomy tube must be adequately lubricated. Prior feeding is very important to ascertain the patency of the gastrostomy or jejunostomy tube. The peristomal skin should be assessed and dressed regularly with a skin protectant in order to prevent it from breaking down. Summary of Study Session 4. In Study Session 4, you have learned about the purpose for insertion of an NGT in client's care, the requirements needed for NGT insertion procedure, identify the nursing actions and rationales involved in the insertion of a NGT, the requirements needed for NGT removal, identify the nurse's actions involved in the removal of NGT, the nursing procedures in relation to the administration of NGT feeding, the different rationales behind nursing actions in relation to the administration of NGT feeding, the nursing procedure actions in relation to the administration gastrostomy or jejunostomy feeding, the different rationales behind the nursing actions in the administration gastrostomy or jejunostomy feeding. End of Study Session 4. Thanks for listening.